Welcome to Diabetes Day by Day, the American Diabetes Association's official podcast. This month's episode is titled, Science Advances, So Do We. Keeping up with diabetes management. Every year in June, new advances in diabetes management are presented at the American Diabetes Association's scientific sessions, which this year was in Chicago. Attending this meeting is just hard to describe. You can feel the excitement in the air, and just to be part of over 10,000 people who gather from all over the world with a single purpose in mind, which is to contribute their part to advance care for people with diabetes, with type 1 and type 2 diabetes, as well as obesity. And it is just invigorating. Today, we're going to try and share a bit of that excitement and some of the knowledge that was shared at the meeting. The other thing we're going to try and do is talk about when new knowledge comes out, how do we make use of that as patients if, when we go in for our visit, we know that our doctor may or may not have heard of that thing that came out 3 weeks ago that we feel is important? Because one of the things that Sarah and I keep coming back to is the core mission of this podcast is to empower people with obesity and diabetes to take control of and be a part of the team of people that cares for their own diabetes and or obesity. I'm Dr. Neil Skolnik, professor of family and community medicine in the Sidney Kimmel Medical College of Thomas Jefferson University. And joining me today, as always, is my co-host.
Thanks, Neil. I'm excited for this discussion. I'm Dr. Sara Wettergreen, an associate professor at the University of Colorado Skaggs School of Pharmacy and an ambulatory care clinical pharmacist.
And joining us today to accomplish this high goal is Dr. Osagie Ebekozien. Dr. Ebekozien is the Chief Quality Officer and lead of the American Diabetes Association's Quality, Primary Care, and Health Access teams. Welcome, Osagie.
I am so honored and thrilled to be here and really looking forward to a great conversation.
And also joining us is Dr. Marlon Pragnell, PhD, who is the Vice President of Research and Science at the ADA and oversees the development of the scientific program for the ADA's scientific sessions and leads ADA's research programs. Marlon, welcome to our podcast.
Thanks so much. Great to be here. Looking forward to the conversation.
Osagie, let's start with you because you gave the opening keynote address at the scientific sessions titled From Standards of Care to Standards of Practice, really discussing new ground about how important it is for us to translate and how to translate all of these complicated areas of knowledge into clinical practice where it benefits people. Can you tell us about that?
No, I appreciate that opportunity. And, again, it is a big privilege for me to share. And diabetes is very personal to me. And my wife lives with type 1 diabetes. She was diagnosed as an adult. So I live with the day-to-day reality outside of being a medical doctor myself, a caregiver for someone living with type 1 diabetes. I shared during the keynote that I lost my late grandmother to complications of type 2 diabetes. So it's also something very personal to me, both type 1 and type 2 diabetes, and I've lived those experiences. One of the challenges early on in my wife's diagnosis with type 1 diabetes is how long it took for her to even be offered diabetes technology. And I happen to be in a privileged position where I'm a physician, I'm working in the diabetes industry, and she's also very educated. But with all of that, it still took 3 years before there was a conversation about diabetes technology. And I'm talking 2016, 2017. So this is not 20 years ago. This is just a few years ago. And the reason why I bring that up is those experiences that I faced and we faced as a family really made me to start to think about if in my privileged position, knowing what I know about diabetes technologies, it still takes 2-3 years for my wife to get offered, and I had to have the conversation with her. I have to offer to even have the conversation with the diabetes doctor. It took a while for that to happen. It made me start to think about the other people living with diabetes and obesity, type 1, type 2 diabetes, that might not have the same level of exposure and privilege and knowledge like I do, and just how long this happens with them. And one of the things, as I go around the country, I started to hear stories like this on this is how long it took me to be offered a CGM, or how long it took me to be offered an insulin pump. So that has sort of fueled my passion for this conversation. Every year we put out great science, but how much of that science gets to people living with diabetes today and tomorrow? And that's what motivates me. That's what pushes me. And what we're doing at ADA now is really to amplify that effort. ADA has always been involved in trying to push this, but this role, and this is the first time ADA would actually have a chief quality officer role. So ADA is also making an investment in the space to say, yes, we're putting our money and our feet on the ground, that everybody with diabetes deserves to get that science, that insight with them day to day. And I will speak more in the conversations on more specific things we're doing. But I just wanted to start with why this work matters to me personally, and let the listeners know we are coming from this from urgency, and we're coming from this from a space where there's work to be done, and we're bringing in all of our resources to bring these standards into routine practices. And there are many things we're doing now that I'll speak on throughout the course of the conversation.
Osagie, and it's interesting as you say that, how long it took for the diabetes technology that's been there for a while to be used by your wife. I think also of new medicines, things like the SGLT2s and the GLP-1s, which the American Diabetes Association really put at the front of care because of their beneficial effects for people who are at high cardiovascular risk or who have existent cardiovascular disease, in decreasing cardiovascular endpoints, the beneficial effects in heart failure and kidney disease. And yet when we look at prescribing patterns, we see that there hasn't been the uptake. And similar to what you said about diabetes technology, it's been a few years now that we have the firm evidence of their benefit. There has not been the level of uptake that we would have expected given the degree of benefit. So it's really a tough issue. What do you see as some of the ways that help us move forward with that?
It's a great question. I think one of it starts with really looking through this data to understand exactly where we are, and as it relates to these issues. And I think you alluded to that in your conversation, Neil. One of the things we're doing now is to shine light on where are those gaps, where are gaps in access, where are gaps in implementation. But we take it beyond that. We go a step further to look at how do we design collaborative interventions or solutions to address this, specifically in the primary care setting. And primary care, because close to 80% or more of people living with diabetes and obesity are being cared for in the primary care environment. So two things we're doing at ADA as relates to primary care right now. First is we have a group we call our Primary Care Council. This is a network of 9 major national associations. So we have the Nurse Practitioners Association, Physician Assistants, the Pharmacist group. We brought all these groups together to answer one key questions on diabetes is a team sport. Diabetes takes all of us. We need the physicians, we need the nurses, the nurse practitioners, the diabetes educators, everyone that has a role to play. How do we help educate them on some of these new standards? How do we help share resources that the ADA has? How do we help connect with them on what are some of their own friction points? What are, from the perspective of a nurse practitioner or a physician assistant or a pharmacist, what role can they play? How can they get involved? So this is a very active group. We're having a lot of conversation. We're taking different standards and the standards of care and having that conversations and making tweaks to our implementation, making tweaks to how the nurse practitioner can be involved in the obesity conversation, what toolkits is available, how can they modify that to different lengths, and then take that to their own constituency, to their community. But we're moving beyond that. We have a group we call the Primary Care Alliance at the ADA. And this is a network now of over 4,000 primary care providers, practitioners across the country. What we're doing with this group is these are well-minded physicians and care team members that are interested in ongoing improvement, ongoing process changes. So we work with them to take a specific standard. Let me give you an example. Our ADA standard says we need to screen people with diabetes for diabetes retinopathy, which is eye disease as it relates to diabetes. But the reality is that's not happening as frequently. So we take these recommendations and the standards around diabetes retinopathy or screening for chronic kidney disease, which is another project we're working on, or offering diabetes technology in chapter 7 of the standards. We take the specific chapter and the specific recommendations and then test out how do we make changes, process changes in the local primary care clinic. Sometimes it's a clinical decision support tool where we work with them on if a patient comes in that has this is the next step. This is what you do next. That's what you do next. And in some of these centers, we're incorporating that into the electronic health record because that's the standard and it's been for years. We want to make it easier for the MDs, the DOs, the MPs, everyone that is touching that patient. You log into your electronic health record and you can see what that recommendation is. You can take action. We're also creating a community where we can share those best practices with each other. So you can have a primary care provider working on improving kidney disease screening and management, share with another primary care provider their best practices. So we're creating a learning forum, a learning community to amplify those gains so that we're not reinventing the wheel. And we're truly at a place where we're moving from these are all great knowledge to ensuring that it's in your local practice and you know where to find it, you know where to plug in, and you know where to be a part of that. The last program I'll share as an example on this, which is also exciting, it's our work in the inpatient setting. When people with diabetes get hospitalized, there's a lot that we know about how to care and manage for them. So I work there through a group with Leapfrog that certifies and rates hospital systems. We partner with Leapfrog to create a program based on the ADA standards of care for managing diabetes in the inpatient setting. We're working now with Leapfrog, and this is our second year of doing that, where we're taking those standards and we're evaluating hospital systems across the country on how well they are meeting that standards. But more importantly, we're supporting them to implement those standards in their hospital setting. So there are over 20 different initiatives like this that our team is testing out across the country. And we're looking forward to what's working and what's not. And then we'll share this, scale this, also support advocacy in the space. So I get very excited about this, Neil and Sarah, because it is something that we're truly passionate about.
Your excitement and enthusiasm comes through, and this is very, very important work. It's interesting. You mentioned retinopathy, and earlier you mentioned technology, and that translation of with retinopathy, we've had so many patients who we refer to see the eye doctor, and it's hard to get in there, and it's another visit, and diabetes is complicated enough. And what a difference it made when we could have a retinal camera in our office. Our MA takes that picture, it gets sent to the expert, and without having to make another visit, our patients are screened by experts for retinal disease. And I think your point about how, and we learned that from someone else, right? That point about best practices being shared and then taken up and creating that feedback loop is so critical. I want to come back to some of those points, but first, Marlon, I want to turn to you and ask you to share your perspective on the science sessions.
Yeah, sure. Well, the scientific sessions is absolutely amazing. It's the world's biggest, most important meeting of scientists and researchers, policymakers, everybody coming together to talk about diabetes and diabetes therapies, everything from basic science all the way through to implementation science. So we hear a lot about drugs and therapies and so on, but also the conversation is also about how to implement this, how to get it to patients. That's why Osagie gave the keynote lecture. To how do we get all this exciting research to individuals, to patients? And when you look at scientific sessions, I mean, it is an amazing meeting. And I, just look at some of the history. For example, the DCCT trial. The trial that really kind of showed everybody how important it was to maintain tight glucose control to avoid complications. That was first presented, I think, about 30 years ago at scientific sessions in Las Vegas. So, I mean, all the most important science comes out. And since then, I mean, 30 years ago, but look at us now. We have technology, we have CG, even then the CGM was a pipe dream. CGMs, we have pumps, we have now technology to link the pump and sensor, to create AID systems, all these tools that are, and we're seeing at scientific sessions, it's the place where the proof that evidence-based research is presented to show these things actually work. And the data is presented, it's published in major journals and so on. It's really now up to people and clinicians to take this and implement it. A key thing that we have is, standards of care. The ultimate goal of research, my feeling of research, the research that we fund at ADA, is to change the standards of care, to modify the standards of care. Everything that we support, we want to make sure that this actually gets to people. And the way to do that is to take the science, show it really works, and take it and publish it. And then ultimately, if it meets that criteria, then it goes to the standards of care, and then it becomes adopted. The next step is adoption. And that's Osagie's expertise, how to kind of get these to people. And that's a key question. That's a conversation that happens at the scientific sessions as well. And also too, that there's a whole area of implementation science. We think about, science is doing research in the test tubes and Petri dishes and so on. But there is also this other later, more stage of science where it's how to really get this to people, how to get clinicians to actually use it, to use the science, to use the standards of care, to really impact change. And also in addition to that, it's not just impact change, but to people who need it most. Those that don't have access to care, don't have people that are marginalized, for example, or people that don't have may not have obviously some people are more fortunate than others in terms of access, and so those are questions as well that are addressed at scientific sessions. And so this is a huge forum. It's just a massive, amazing forum that brings everybody together to talk, to communicate, and to try and move the whole field forward. And it's very, very exciting.
I can really feel the excitement coming from both of you. I know, Neil, you were able to attend the meeting. I unfortunately couldn't go this year, but I feel like I was there just from hearing your excitement from coming from this meeting. And it really is incredible to think about the amount of science and research that goes into not only creating the standards of care, the solutions that lead to their implementation into practice, but also the science that fuels the creation of those standards of care. We have to look broadly at evidence to evaluate what will become a standard of care. And some things do and some things don't, just based on the evidence and the way that things are researched. Marlon and Osagie both, I'm curious if there were any particular standout points that you took away after attending that you were excited about in terms of new evidence that you'd want our listeners to know?
I could say a few things. I mean, in going to scientific sessions over the years, I used to go as an attendee, right? And now actually I'm on the other side. I'm actually part of the whole program planning. We had this amazing, a panel of 34 experts that come together and think through the whole, what's hot, what's really important, what's critical. And they come together and discuss. And then we have all the diabetes world kind of submitting abstracts. And so these come together to create this amazing meeting. And some of the things that really kind of struck me this time was, the progression. You see over the years, you see research on posters, research in these session rooms and so on, but a progression. And then all of a sudden you see it after a while, if the science is really good, you see it on the exhibit floor, devices, technology, drugs that you can see being used for people are being used in therapies and so on. So it's really very gratifying to see that. And I think some of the key things that I think jump out at me I really like this the stem cell derived beta cell replacement therapy. That really is just amazing. I mean, absolutely amazing. Where you can get an unlimited supply of stem cells, change them into beta cells, transplant them into individuals. There was the trial mentioned I think 10 out of 12. Sorry, 10 out of 12 individuals went off insulin. Every single person actually met the endpoint of tight control and so on. Amazing. I mean, obviously they have to take immunosuppression therapy and so on. But I think, this is just the next step. I would imagine people are working on, immune therapy, like ways to kind of cloak the beta cells and so on to make them less sensitive to the immune system, things like that. I thought also to the GLP-1s, the incretin story, the Ozempics, the next generation. I think people are looking at the next generation now, better weight loss with preserve muscle mass and so on, things like that. I mean, it was an amazing meeting. I mean, I know Osagie probably has lots of suggestions as well, but there were so many things, so many great presentations and so on. I counted like 6 New England Journal of Medicine journal papers, and when it comes out in New England Journal, it's really good. It's really good.
And I would like to add that I was, in addition to all of the great things Marlon shared, I was also intrigued by many of the clinic community interactions and presentations. And what I mean by that is actually seeing the power of community relationships, seeing the power of engaging people living with diabetes and obesity in the science itself, seeing the power of they being involved in testing out ideas too and going to their providers and having those pieces. There was a session in health equity or health access where there were community providers, the food bank, different kinds of community interventions, the Black Nurses Rock Foundation. So there are many of those sort of community-based programs that we know has a real role to play. Community health workers, they are having their own spotlight too to share from their perspective how they can be a part of the solution, which for me, I think that's one of the beautiful things about how the science shapes up.
I so agree with you. It's interesting as we're talking, and I'm beginning to think about different stakeholders. And we started by talking about clinicians and how important the education was in the translation of knowledge. And then, Marlon, you mentioned how research goes from posters to presentations and publications, and then you see it on the exhibit floor. And that makes me think of industry and how important industry is in helping that translation of knowledge. I think about when we talk about diabetes tech, Osagie, where you started, for us in primary care, I think one of the big leaps in diabetes tech occurred when industry started advertising CGM. The people I learned how to read CGM were, and okay, I'll share it on this podcast, were my patients who came in with a device and said, how do I use that? And made me feel, oh, I better learn this one quick. And we would go over it together in the office. And of course, I did my homework and learned a lot on my own as well. But that drove some of the uptake. And that last and most important stakeholder, Osagie, is who you just were talking about, which is people with obesity, people with diabetes, who are there at the scientific sessions, who teach us. I went to one of the most exciting sessions I went to was a session on obesity, bias, and stigma. And one of the speakers was a woman who had obesity through most of her life, and she gave a very moving discussion about what this meant to her and the biases that she encountered. And even as someone who is well familiar with that issue, her perspective was so important in helping me grow further to understand the challenges. So I think that there's all these different pieces that come together in the scientific sessions. Sarah?
Oh, I agree. Although I couldn't be there, I love reading the new evidence that comes out. And in my clinical role, I do often get questions from patients about different evidence that has come out or different articles. And so sometimes it keeps me on my toes to see what was on the news this morning, what article came out that they're talking about. So I do think those questions come up, and some people might feel confident in bringing up those questions to their care team, but I think some people might feel a little bit more hesitant, or they might be concerned that they'll seem like they're questioning their provider if they bring something like this up. So, Osagie, I'm curious if you have advice from your physician perspective and your ADA perspective. How would you encourage someone to bring up new clinical evidence or these types of topics with their care team?
No, that's a great question. And I should add that ADA also has a resource for patients called the Standards of Care for Patients. And that is written in plain, easy, non-jargon language that patients can pick up and read to get a sense on what all of this old science is about. So that's a resource for the listeners that want to check that out. One statement that I encourage patients to use is lead with what matters to you. So you go into the provider's office, and most time you might get a question, oh, what is the matter today? Or what are we here to talk about today? Or what's going on? But to actually change a little bit of that conversation, as a patient, you are in the driver's seat. You have the most at stake. You are co-leading and co-driving that. And that is something too that I discuss with my wife all the time, because she, like I shared, so I'm like, you're in the driver's seat and the provider is a co-driver with you. So that's shared decision making. So lead with, this is doctor, nurse, any member of your care team, this is what matters to me. And sometimes what matters to you is, I want to make sure that I don't have complications from diabetes. Doctor, what are my options not to have complications for diabetes? I want to make sure that I don't have heart failure from diabetes. That's what matters to me. I want to make sure that I'm not disturbed with the burdens of diabetes. So I think it's important to pause as a patient and think about what truly matters to you, and share that with your provider, share that with your doctor. And if you're familiar or you see a particular tool or a medication or something that you think might help you with that, lead with that conversation. And this matters to me. I saw this tool or this technology or this new medication. Do you think it will help with that? Because sometimes it's a good match, and other times, but once the provider understands what matters to you, there are other times where there might be other complications you might not be aware of, other insights you might not be aware of that might not make that specific to the best fit. But when the provider understands what matters to you, then you can both talk about other options of, oh, now that I know your sleep quality matters to you, this might not be the best fit in my opinion based on X and Y, but this might be something else that might be worthwhile considering. I think just leading with being very clear on what truly matters to you and knowing that you're in the driver's seat and you're going to co-pilot your care with your provider.
That's excellent. I think that strategy will be really effective, and we'll be sure to link the patient access version of the standards in the show notes for others to find easily if they want to look at that a little bit more. Marlon, I'd love to hear your perspective on this as well, thinking also from that science side of, I know sometimes scientific papers are even complicated for us as clinicians to sort through. So how do you recommend that people living with diabetes or obesity get familiar with emerging evidence that comes out?
Yeah. ADA provides amazing resources. And one thing you can always trust ADA to make sure that it's evidence-based science. You'll hear information from all over the place, especially now. You hear all kinds of things everywhere. Come back to ADA. Always come back and check to see what's really real, and what's valuable. We have incredible resources on our website, as Osagie mentioned, so I think that's a kind of a key message. And another thing too is that also to the importance of science. Everything that comes to patients, to individuals, all the benefits comes through scientific research. And we don't know, a lot of people don't know where or how some initial research might not seem relevant. For example, I'm giving an example, like the Gila monster, the story about the Gila monster, the initial incretin, so to speak, that was lizard spit. People funded research in lizard spit. That became blockbuster GLP-1 incretin weight loss therapy. So really the key thing there is, don't presuppose, follow the science, follow the evidence, and go with that.
Fantastic. We only have a few minutes left. Osagie, do you have any final thoughts for our listeners?
I do, and I think that is we want to hear from you. We love hearing from you. If you are a provider listening in the care side and you have ideas or you're doing innovative things, we welcome you sharing that with us. quality@diabetes.org. That's the email address that a member of our quality team takes a look at that and would respond. So if you're on the care team or even on the patient side and you've seen some innovative things happening in your clinic, share that piece with us. And then if you're a patient and you're still not sure how to navigate things or where to go next, ADA has an 800 number. It's 800 diabetes. And I'm sure we can share that information as well. So you can call that number, 800 diabetes, and there's someone on the team willing to help navigate you through that. So we're here and we're fighting, and we want to make sure that everyone living with diabetes and obesity gets that standard today, and we'll be with you as partners in this journey.
Excellent. Marlon, your final thoughts.
Osagie covered it. Thank you so much. This is actually an excellent conversation. We're doing our very best and trying our best to make sure that all the science gets to the patients, to individuals who will most benefit. So thanks for the opportunity to discuss this.
Thank you. Sara, your thoughts.
Mine is just to add one more nudge of encouragement. If there's something you've read about, or you read the standards and you think, does this apply to me? Or maybe you're reading through your medication side effect list and you're hesitant to continue taking your medication because of a concern. Talk with your care team, your provider, your pharmacist, your nurse, your diabetes educator. There are so many members of the care team there who can provide some additional information and have the conversation with you so that you feel empowered and informed in your decision making.
Sara, you are so right. And that is why we do the podcast. Our goal is to empower our patients to be able to take care of themselves. We covered a lot of ground today. We talked about all this exciting science that will change the way we provide care, the way we as people with obesity and diabetes will receive care tomorrow, 5 years, 10 years from now. And Marlon, I love that you mentioned the word trust and that ADA is a trusted source of information, because I often think of something that I read from the former Secretary of State, George Shultz, on his 100th birthday, published an essay in the Washington Post and the title was Trust. And he said, when trust is in the room, anything can be accomplished. And that is critical because we live in an age where there are lots of information sources. When you come to the American Diabetes Association, you are getting really the best information out there. Finally, thanks to our listeners. You are why we are here talking about all this information. We hope you enjoyed and benefited from the things that we talked about today. If you have thoughts that you'd like to share, don't hesitate to leave us a voicemail by calling 703-755-7288. Again, that's 703-755-7288. We'll leave that in the show notes. We do hope to hear from you. For the American Diabetes Association, I'm Dr. Neil Skolnik. Thank you so much for listening.